Okay, so let's go ahead and get started with today's session. Welcome everybody to our second session of our community of practice on prevention and practice on behavioral health amongst individuals with disabilities. In today's session, we'll be focusing on evidence-based prevention approaches for substance use disorder treatment. As a reminder for everybody that all participants are muted upon entry, please make sure you engage in the chat if you have any questions. Or if you would like to also participate verbally, you may also raise your hand or just simply unmute your line. This meeting is also being recorded. The slides and recording link will be sent to you all via email after today's session. And again, please briefly introduce yourselves in the chat and let us know your name, your state, the organization that you're joining us from, and your title, and also what brings you here today. So thank you everybody for joining. And also just a quick reminder that today, since the session is meant to be an engaging session, and we always like to have our participants engage during our case studies, please feel free to unmute your line again during our case study questions, and just be ready to participate verbally. If you're not able to participate verbally, you can also do it through the chat. All right. And then with me today, I have Dr. Kevin Lombardi. He is our Director of Research. He will be our main presenter for today. And my name is Filipina Sandoval. I am the TTA Manager at SHPH, and I will be co-moderating with Dr. Lombardi on today's session. And now, without further ado, I'll pass it on to Dr. Lombardi to get us started.
Hi, everyone. Welcome. Welcome back. Today, we will be continuing our conversation about youth with disability. We'll be going over a prevention model called the Take It Personal prevention or intervention. It's a group-based therapy system for youth to adult age from 14 to 30. It's a very adaptive model. It's one that focuses on personality traits that are high risk. So we'll focus a little bit on those as well. And it's designed to provide the patients with cognitive strategies for reducing their risk for substance use. It's a very empowering program, and it's one that I think you should practice at your health center. Next time we'll be taking a switch and going to veterans health. We'll also be doing but today our case study will be focused on physical disability and substance use in a youth participant. So we will follow them through the primary care center into the home, and we will look at their risk factors, protective factors, and get better insight into how individuals can switch from being at risk to not at risk, or that risk being reduced as much as possible. Next slide, please. Do we have any community health workers or social workers in the audience today? Pop something in the chat if you are, and otherwise, next slide. Let's talk a little bit about Take It Personal. It's a link to the source is at the bottom left. These slides are made like consulting presentations, so feel free to distribute them. The links are all live and will take you right to the research article that both describes and validates the intervention. Take It Personal is a group-based therapy designed for both youth and young adults. 14 to 18 and 19 to 30 are the two different groups you can break it into. What it's designed to is take vulnerable youth and young adults, in particular those with cognitive disabilities and high risk personality traits, and to educate them on the things that they can do in certain circumstances to avoid using substances. Now, we talked a little bit about impulsivity last time. Impulsivity is when an individual lacks the executive function to make a good decision in a certain circumstance. When you have someone who lacks executive function and they're in a circumstance with significant peer pressure or unclear signals from adults and unclear role models, unclear models for appropriate behavior, those risks compound and make it more and more and more likely that an individual will try substances and get addicted. Uh, Take It Personal focuses on giving them as much control as possible in those circumstances. Of course, we can't change the circumstance. The internal locus and the external locus. Remember, FIDE? The internal locus and the external locus. We focus on what the patients can control, and we give them all the cognitive and behavioral tools that they need to be able to do that. Now, Take It Personal focuses on three main things: the education, the coping, and the computation. Making individuals aware of how their brains work, of how peer pressure influences their behavior, gives context when there was no context. It makes it easier for them to understand when they are in those circumstances where they may be at risk or the outcomes may be bad, so they can, when they can, remove them from those. Those are the coping skills. Removing yourself from opportunities for substance use, knowing how to say no, and a thought process and a scaffolding behind that no. Not just knowing that no is an option, but knowing how to say it in a way that preserves social face and so forth. And of course, the cognitive coping skills. As you ever hear you are what you eat, Fide? You ever hear that? My mom says that a lot. She bakes a lot of sweets though, so different parts of what she's saying contradict each other. But you also are what you do. Every time you do something, Fide plays the guitar.
Mm.
And when Fide sits and plays the guitar, I've seen her videos, they're very good. Um, uh, she has to memorize where to put her fingers. How do you do that? You do it by practicing, right? By physically doing it. The things we do rewire our brains. A guitar and learning where to put your fingers is a good analogy for being able to function in a social situation. When you are in a social situation and you are doing the right things, when you're saying no, when you're removing yourself, when you're using these behavioral coping skills, it trains your brain. That is the cognitive coping skills. Much like it becomes very easy to put your finger on a fret that you needed to think about before, it becomes easier for that individual to remove themselves in a way that they feel is doable and is possible. It empowers them. It's literally a scaffolding in the brain. So as they learn these things and as they do them, they change their brains in ways that help them in a lot of other ways as well. Increasing executive function isn't just important for substance abuse, it's important for functioning in the world. As you can tell, I'm a big fan of group therapy. It really does rewire the brain, in particular for our youth, and it's a good intervention. Next slide, please. Um, Today, we're going to focus on sensation seeking a little bit. It's relevant to our case study, and it's one of the core personality traits that drive substance use risk, in particular in youth and young adults. Um, Sensation seeking is associated with risk taking and reckless behaviors. Substance abuse is just one of those. There's a lot of other safety issues that come along with sensation seeking. In particular, when there is a cognitive deficit and the executive functioning, which typically allows us to say no and override the more emotional aspects of our brain, is limited. Um, so adolescents lack the ability to say no in many ways, and they lack the ability to avoid the risks. This leads them to greater vulnerability to experimentation. In particular, when there's existing behavioral health issues like anxiety, like depression, it is hard to say no when there's a chemical reason to say yes. Difficulty with delaying gratification, and it's another major issue. and lower inhibition in social settings. These are the life of the party individuals. And when they get into those social settings, it's very difficult for them to get control. The comorbidities with this personality type are significant. It occurs with aggression, rule breaking, and ADHD-like behaviors. These, in addition to creating a lot of other issues for life, compound the substance use risks. Great source that studies that on the bottom left. Print it out, read it with your colleagues. Tell me what you think. Next slide. So, where there is a risk, there is a risk management. When we are working with individuals that are sensation seekers, and of course, how do we identify this? Through the BSSS, the Brief Sensation Scale score. That puts individuals in different categories so we can really understand what their behavioral impetus is. For individuals who are sensation seeking, emphasizing positive outlets and educating them on strategies for self-regulation are resilience builders. So the positive outlets is the big one for these individuals. They need stimulation, and often they are seeking stimulation because they're not getting it in their normal lives. Now, consider someone who has a physical disability, and it's difficult for them to do activities like sports or even community theater or something like a painting class, or to do things with kids their age. It creates barriers that often don't allow them to exercise their brains and their bodies the way they should. Those barriers are societally introduced, but they are navigable. There are sports leagues for individuals with physical disabilities. There are programs specifically designed for individuals like this that allow them to get the full experience of someone who does not have a disability. And that's incredibly important for this demographic, the sensation seekers, because if they do not get activity from something positive, and something negative is there sitting on the counter or in the neighborhood, it makes it more and more likely that they're going to say yes to that because they need that. They need that. Their brains scream for it in their heads. Um, so anyway, and the self-regulatory skills. That's what dampens the screaming, the voice. The directing the patients through structured, stimulating, and high intensity activities, again, sports, dance, art. At times, these can be very helpful for the disability as well. Consider someone with a physical disability, cerebral palsy. Doing a sport that works on their upper body strength can build confidence and increase mobility for them. All of a sudden, they start feeling less like someone with a disability and more like just themselves. And that's the goal. That confidence adds to self-regulation. It adds to mental health wellness, and it lasts as well. It's not just like a medication where there's a half-life and it runs out. If you give someone a good coping skill, that's something that can stay with them for their whole adult life. And in particular, when we're talking about youth, that capacity has longevity. So think of it like this. It's an investment in their future that has a compounding return. They will continually benefit from that. But to get that, you've got to teach it. Next slide, please. When we're working with patients like this, we want to redesign their environment, including their home environment, so that high risk options are less available. That's the first step. Now we have, I think some of our colleagues last session spoke about youth and role models. It's not always easy to just remove risks from a patient's life. But the situation is always in some way manageable and improvable. and you may not be able to fix everything. Say if the father is a substance user and lives at home, or it's otherwise unavoidable in the neighborhood, it may not be possible to eliminate that completely from the patient's life, even through close management. That's actually more the reality of most situations. What you can do is manage it where you can and help them to navigate it as well. That reduces the risk significantly in some cases. And in many others can be the difference between success being no substance use and failure being that substance use. So removing alcohol or substance paraphernalia from the house, that's a first step out. Emphasizing the importance of a sober and healthy home. A lot of times when you're working with pediatric patients, you don't just have one patient, you have many patients because the family members, and involving the family in those conversations is how you do this. Getting them together either in the exam room during the clinic visit, or if there's anything outside of the outpatient setting, making sure the parents and the caregivers, as many as possible, are involved in the conversation. Uh, Connecting folks to positive mentors when they're not available is another uh, a great strategy for this in particular. Know the nonprofits, know the church groups, the local organizations that provide mentorship to local youth. Uh, these are like gold mines for mentors. They're individuals that are motivated to mentor, who enjoy doing it. And guess what? When you're motivated and you enjoy something, you usually do it pretty better than if you don't. Very good track record with these individuals. Um, so put them into your community development quiver. And things like cooking, gardening, nutritional programs, they help to eliminate the foods that drive unhealthy behavior. Processed foods, snacks, it's amazing how many kids really just live off of these things these days. These foods lower cognitive performance and make turning to high risk behavior cognitively much easier for patients. Just replacing those Doritos with pears and oranges is going to have a cognitive effect on these patients, a measurable one with measurable outcomes. And if you think over years, how those compound, some dietary education here, some nutrition education can really make someone's life a lot easier, a lot easier. Next slide, please. So just to briefly go over how to set this up and inclusion criteria. The inclusion criteria for the TASIP personal model are patients 14 to 30 with mild intellectual disability. They must also have a co-occurring mild substance abuse. That's DSM-5 criteria. That's a diagnosis. And they must fit into one of or more high-risk personality groups, such as our sensation seekers or those who exhibit significant impulsivity. You determine that by giving them the screener that I went over last week, the BSSS, which is on that slide, by the way, if you need it. The contraindications, those who don't fit into this program, moderate or severe intellectual disability, it's just not designed for that. That needs more specialized care. Um, Moderate or severe substance use, more specialized care as well. Individuals experiencing extreme aggression or outbursts, of course, this is a group environment. We need to protect safety of them and others. And psychotic symptoms, hallucinations, and delusions make it very difficult to engage in group-based therapy in this context, and that requires more specialized care as well. Next slide, please. Okay, let's talk about it. What are the benefits of using peer-based therapy with disabled youth struggling with SUD? What are the disadvantages? Let's take a moment and think about it. Use the chat. Let me know what you think. This is an important and interesting topic. I'm going to give a moment, and then PDA and I are going to start talking.
Yep.
What do you think?
Also, you're more than welcome to mute your line if you would like to participate verbally.
So, peer-based therapy. What do you want to start with, the benefits or the risks?
The benefits.
Okay, let's do that. Um, 15-minute clinic appointment, is that enough to delve into the issues I was talking about earlier, like to develop cognitive skills or behavioral skills? Is that enough?
No, not at
Yeah,
all.
it's not. It's not even close to enough. You need a lot of time, and you need a structured setting. So the first good thing about based therapy is it's longitudinal. So you have time to build cognitive skills and behavioral skills over time. These things are like they're like scaffolding and they are layered. As one builds cognitive skills and behavioral skills, they build on top of each other. Now, let's add the addition of the peers there. What's the benefit of peers versus not having peers in that circumstance?
I think you could have like peers could be also include somebody that has a shared experience. Um, I think.
100%.
So so
How
maybe
relatable
having
is someone like you or me
mhm.
to a 14-year-old and one with a disability, nonetheless?
Yeah, no, not too much.
Neither you nor I have that experience, and it creates an experiential wall. We can cross that in some ways as the patients allow us, but it requires being able to have a peer to reflect and share experiences that is comparable age to them allows those coping skills to bounce around. Think of the group therapy as a neural nexus in a way. One individual, if we're talking about avoiding stimuli that are bad or of being able to say no. Individuals are going to have different strategies for that, and they're going to be able to build on top of what they say. Asking one patient to discuss what they would do, and then reflecting on that, and then allowing another patient to say what they would do, you'll notice that they kind of build on each other. They'll say things that are relevant to the other one. Well, what I would do in that circumstance is this, or what I would do in this circumstance is that. It allows them to do that. It builds capacity.
Mhm.
Now, let's talk about the disadvantages. Individuals with individuals who are experiencing severe anxiety, who have difficulty being in group settings, or who experience extreme aggression, this may not be appropriate for them. It's really a personality pick. Some individuals are completely against doing therapy in this. Excuse me, I had to shut the door there. It requires a discussion with the patient and the caregiver to see really what is more appropriate for them. Um, Next slide, please. Into our case study. John is a 16-year-old male with a past medical history significant for diplegic cerebral palsy affecting his lower extremities. He ambulates with forearm crutches and has mild lower extremity contractures. His cognitive function is normal. John attends a mainstream public school and is enrolled in standard academic classes. He has no prior mental health diagnoses and no prior substance abuse treatment. He has no chronic pain requiring prescription medication, which can be the case with these patients. Next slide, please. John lives with both parents and a young sibling in a suburban community. His parents are attentive, but describe him as increasingly private over the past year. He has stopped participating in school activities, citing fatigue and a lack of interest. At home, he spends most of his evenings alone in his room, often on his phone or gaming online. So we have an individual that is increasingly isolating himself, and appears to be withdrawn emotionally and physically from the outside world. Okay, next slide. At school, John reports difficulty forming close peer relationships. Although he is academically capable, he reports feeling different and socially individual, and socially invisible. Upon questioning, John notes that over the past year, he has experienced repeated teasing related to his gait and assistive devices. He also reports being excluded from social events and group activities. These experiences have led to increasing social withdrawal and avoidance of school-sponsored activities. Well, can you blame him? I don't blame him.
No.
For a child of John's age, if he's going to school and he's being teased constantly, or it's happening on even in a regular basis, all it needs to be is one comment a week, really. It compounds over time and has in this case, it's causing him just to be socially withdrawn. It's very sad to see this because it often happens to very happy and well-functioning children, and they go to middle school or high school, and kids just get mean, and it leads to this sort of withdrawal. Is that withdrawal one of that social withdrawal a risk factor or a protective factor for substance
Um,
abuse?
I could think of it being as a protective factor for him.
It's actually
He
the
could
opposite.
see. Mm.
It's a
Oh, okay.
risk factor. Because
Sounds-
what does he feel that makes him want to withdraw? What what feelings does he have?
He's feeling different,
I'm speaking specifically
isolated.
to, yes, different, but when you see someone withdrawn, like physically, you can physically see them in it when you walk into an exam or you walk into a room. You can see them physically withdrawn. Is that a happy individual?
No.
That is an unhappy individual. And these individuals often experience depression and anxiety. So, if we're talking about a different context where there's a dangerous circumstance, sometimes withdrawing yourself from that is good. But if you are withdrawing yourself from society because you are depressed or because you are anxious, that's something very different. That is a risk factor. And it's a risk factor for substance use in this age, and it's a big one. Next slide, please. Excuse me. Over the past 2 months, John has demonstrated the following. We get some collateral now. One, declining grades in two subjects. Two, increased irritability and mood lability. That's a mood that goes up and down, up and down. Frequent headaches and stomach aches without clear medical cause. Decreased motivation for previously enjoyed activity and sleep disruption. He denies suicidal ideation but endorses persistent feelings of loneliness and low self-worth. Hmm. What color would you say these flags are, Fide?
Red.
Yeah, it's Flag
Mhm.
Day in China over here. This is big stuff. Um, and which ones stick out for you?
Um, I think all of them, but mostly for me, the third one, the frequent headaches and stomach aches without clear medical cause.
Yeah,
Um,
yeah, 100%. That's a huge red flag. What's
Mm-hmm.
happening? What's causing those headaches or stomach aches? There's a wide range of things, and not all of them are positive. The anxiety and depression, the behavioral symptoms themselves can manifest as physical symptoms in many people, psychosomatic symptoms. They can also be genuinely pathological or genuinely medical as well. Anxiety is associated with gastric reflux and stomach pain. That's a real thing that people experience. But these happening in constellation get me worried about alcohol use and drug use as well, because it also creates those symptoms. Other red flags, the declining grades in two subjects, not just an accident, it's a trend. Increased irritability and mood lability. Of course, he's a teenager, and folks say to expect these things in teenagers, but irritability and lability are clinical symptoms, and that's severe ups and downs. And even for a teenager, that is not normal. That is a sign of instability in the patient's mood. Decreased motivation, a classic sign of depression, and sleep disruption, also a classic sign of depression as well. So this patient, these dots, they all look like parts of diagnosis criteria to me. Now, when you're getting responses from patients and you start to think like you're looking at diagnosis criteria for a couple of conditions, it's time to start thinking about those diagnoses. So let's see what we can probe out of the patient and his family. Next slide, please. Okay, let's start with the risk factors. What are the big ones? Audience, what do you think? When you think of our patient and his life, what are the risk factors? What makes him more likely to use substances than another patient? We'll start with the behavioral symptoms. We haven't screened this patient yet, but they look like they may be experiencing depression and anxiety. That is a risk factor. The patient's disability itself is a risk factor. Across the board, youth with physical disabilities are more likely to experience depression and anxiety, and thus more likely to use substances, just at a population level. It's a mathematical fact. So there's another one. And thinking at the rest of his history, his academic performance and his social withdrawal makes me think that his personality type may be high risk as well. Let's go ahead and go to the next slide and look what's next. The protective factors. So, what do you think? Jordan, protective factors. Well, we haven't heard anything about substance use yet. We haven't heard anything about violence. It seems like this issue is relatively new, that this was previously a well-adjusted child. And I'm thinking that because the trigger here was the teasing that he experienced at home, at school. The teasing seems like it pushed the behavioral health symptoms, and the behavioral health symptoms are what increases the risk here. This patient was previously very healthy and very happy. So that gives us a baseline that we can work back to. Those are protective factors, and there are important ones. So, other important protective factors in this demographic is a supportive family, family with good role models, and a rich social environment, activities and things and infrastructure in his life that keeps him busy. Next slide, please. So, during a routine follow-up visit, John presents with his parents. This is next visit. To express concern about his mood and his withdrawal, but are unaware of any substance use. When questioned confidentially by the nurse practitioner, John discloses the following: that he is using marijuana 3 to 4 times per week, primarily in the evenings. There is occasional alcohol consumption on the weekends, and he is using substances primarily to calm down, reduce anxiety, and feel socially accepted. That's what he tells the nurse practitioner. And what do you think about that? Does that seem to make sense to you? Does anything pop out as a surprise? What do you think, Fide?
Um, it doesn't surprise me now that, he's providing more information about what he's been doing. Um, so yeah,
Yeah, that
makes
with that
sense.
social withdrawal, and the disappearing into his room,
Mhm.
it makes a lot more sense right now, doesn't it?
Yes.
Um, and it's clear that this is what is filling that emotional hole. That is how the patient
Mhm.
is self-medicating with alcohol. He's self-medicating with marijuana, and he may be self-medicating with other things too.
Mhm.
The feel socially accepted aspect is very clearly said here. That's what he said.
Mhm.
Um, he's experiencing teasing at school. He feels withdrawn, and the poor kid is sitting there at night feeling this way and medicating with this. There are much better ways to manage this that he is not aware of. So this is a perfect patient for intervention. And as we said earlier, given his earlier baseline of relative stability and well functioning, in high levels of functionality, we can get back there. We can walk the patient in that direction. This is a perfect patient for the take it personal intervention. He would thrive in group therapy. Socially withdrawn, issues with substance use, seems like someone who could benefit quite a bit from a reflection with peers that are dealing with the same things. Um, Perhaps understanding or sharing that social withdrawal, sharing that teasing with other kids who may be experiencing that as well would help him to understand it, make it normal, make it manageable for him. So that's the success we want to work towards. Next slide, please. So what's our appropriate next step? Here are the options. A, immediately inform John's parents because substance use by a minor must always be disclosed. B, maintain confidentiality, assess safety, and explore involving the parents with John's participation. C, report the substance use to school officials due to the bullying history. Or D, advise John to stop using substances. What do we pick? Put your answer in the chat, folks. Hmm. Mary, what do you, I see you said B. Sell me on B.
I think this is one point in a longer process. Uh,
Mm-hmm.
even if, I mean, even this one point, talking with John before any of those other things, even if just
Mm.
to say, it's important that your parents know, there's some obligations that I have to report, you know, that I don't want you to have to be doing dangerous things, that I care about you. Be before any of those, even if we also do any of those in the same conversation. Does that make sense?
You mentioned something that I really liked. You said it's part of a longer process. I really like that.
Yeah.
Um, uh, I want you to tell me what you mean by that. And also, please remind us who you serve and how you serve them so we can place you on a map somewhere.
I live on an island, kind of a remote island off the coast of Washington State, almost into Canada. Um,
That's cool.
yeah, yeah, it is. It is. And in some ways, uh, it means you don't really have as much access to a bunch of different services. And so you kind of figure out what it is that is ours to do.
Mm.
Um, and I'm a nurse. I've been a nurse midwife, and having lost hand function, I'm shifting to be a psych nurse practitioner.
Okay. Well, that's actually quite exciting because as you may be seeing in your transition, the brain and behavior is absolutely fascinating, isn't it?
Yeah, yeah, yeah.
It makes you a better clinician the more you know.
Oh, everything does, right? Everything,
Hmm.
everything does. John does. This patient does. Yeah, yeah.
I want to ask you again about this is a longer process, though. I think you're speaking to the longitudinal connection that we would have to the patient. And a word comes to mind for me. Thank you very much, Mary. Um, and that word is trust. Is there a risk to the patient if we break his trust? Fide's nodding. Why is trust important with John?
I think up to this point, he's been able to at least say the things that he's been doing and has been given like a very good overview of what are some of the causes and how that can be addressed. If the trust is broken, he may not be able to share anymore some of that information.
Don't waste it when you get it.
Mm-hmm.
It's not easy to get someone to open up. Sometimes people will just say things, and I've got to say, there's a lot you can do to increase the likelihood of that. If I'm a clinician and I'm talking like this, one of those gets told the details, the other one doesn't, right? I think you can guess which one is which. Um, and when you get that trust, it is a precious, precious, precious resource. Mary told us this is a longer process. Mary, do you think trust has to do with something about how long that process goes? Or am
Uh,
I just blowing smoke here?
we just don't get anywhere without it.
No.
I mean, maybe people who find some comfort in following rules, including patients. Yeah,
Hmm.
maybe they would hang with us just because they understand that rule following is okay or something. But yeah, I can't imagine. I mean, it's so easy to lose people.
So, other than the most structured patients we could ask for, we lost them when we
Yeah.
lost that trust. Yes, and you may have just alienated them from the medical system too, because you're like the other ones, and they're going to remember that experience. Trust is precious, precious. In fact, loss of trust can lead to whole communities removing themselves from the medical system. This happens all over America. It's on us to maintain it. So when you have something like John, the first thing you're gonna want to do is push all the buttons. But involving the parents is something that needs to be done very gently. Of course, if you feel like the patient is at a risk to himself or others, and remember he said no suicidal ideation, and there's no mention of violence. If there was mention of violence, you must report that. You must manage that more directly. That's a safety issue. It's a different animal. Um, with this individual, though, it requires gentler hands. Involving the parents is going to require his consent if you want to keep the trust, or you will lose it. There's no way to do both. No cake can have it too. Experience here. Mary, do you have something to say?
Do I am more and more seeing how possible it is to encourage the patient to be the one to tell the parents or whoever, to tell whoever, with our role being coaching or practicing role playing or being in the room when the patient is talking to the parents or whatever.
Mm, I really like that. And I'll tell you why.
It needs to make sense to our patients that other people want to know, and they
I
get to.
agree. Like, no, please continue.
No,
Continue.
that's it. No, that's it. Just that ideally the patients would get to say. I mean, if the patients are like, fuck no, excuse me, sorry. If the patients are like not up for it, then we have something else to figure out. But it just seems like a good starting place.
100%. And I will say, I'm from coastal New England, which is the opposite side of the country of yours. But the place where I grew up, they called it little drinking villages with fishing problems because there was just so much alcoholism. In areas of the country like we come from, substance abuse is just very, very prominent and normalized. So we need to have a close eye on it. I like what you're saying, though, to take a step back because for the right patient, that builds social capacity. Because when you're coaching them to do that, you're coaching them to communicate better with their parents, with their family. And that's a long-term piece of infrastructure that they can take and build on. So I 100% agree. When you can do that, do that. But I think you can agree, Mary, that that's a very particular type of patient. Some patients may require a conversation together with caregiver and parents and more gentle handling. But when you can encourage folks to do it, do it. My question for you is, how do you encourage folks to want to do something so difficult, so intimate? Do you have any promising practices for us from the bench?
Um, Oftentimes, if for the patient there is at least a person, another person, their person, even if it's parents, and oftentimes there's a bunch of conflict. I Well, I just lead with this now. It's like you got that relationship. Do you know what I mean? Like it's there. I think our patients want people. And they ultimately we're trying to help them contradict that feeling of being so alone. So again, I just lead with that as an offering.
Mm-hmm. Mm-hmm.
And sometimes people are like, no, you tell them. You tell them. I don't want to tell them. But
Yeah.
again, the first step is just offering that.
This patient is withdrawn socially. So, just the process of going through those motions with them helps to solve a problem.
That's
And
it.
that's lack of
That's it.
communication in the family. So you nailed it. I 100% agree. I just wanted to emphasize that that is just so deeply important. Um, we're units. We all live in community. It doesn't matter if it's family, extended family, everyone has their people, but they need to be able to talk to them. And when you're giving them a coping skill like that, you're building really critical infrastructure. And this kid's 16. He can use these things for the rest of our lives. Think of it like this. People like you, Mary, are construction workers. You look all around town, you can see buildings from so many different eras, those were all built by people. But when we look around and see people, what we don't see is that there is infrastructure in their minds. And much like those buildings stay around for decades, the infrastructure you build in someone's mind or enable them to build that lasts for just as long. It lasts for the life of that individual. It can last for longer than a house. So when you do something like that and put a little extra time, you are building infrastructure. And it's not just for the patient. We all live together. We've all got to deal with each other. So when we do that, it's like pouring a foundation. It gives the patient something to put the first pieces of wood on and build off of. And for a patient who has a physical disability, who has a risk of depression and anxiety, they are looking at challenges down the road. It's going to happen. This is in some ways, Our society is a lot more accessible than others, but we still got a lot of work to do. He's going to have challenges. Let's give him a toolbox. Give him a toolbox because he'll keep that and he'll solve other problems with it. So yes, and thank you. Next slide, please. So time to get interdisciplinary. After reviewing John's findings, the primary care team comprising of the physician, behavioral health clinician, and community health worker met to create a coordinated care plan. The discussion centered on John's disability, his recent substance use, and the methodologies that can reliably be used to lower his risk and increase safety. Good job, interdisciplinary team. I love interdisciplinary teams, Fide. Do you know why I love them? No, you're muted.
No? Why do you love them, Kevin?
I love them because there's a ton of stuff that I don't know. A lot of it. A lot of
Yeah.
it.
Yeah.
Like all stuff I don't know. There's bookshelves of it. There's so much
Mhm.
knowledge out there. And I can talk to a behavior, but so what I focus on is being able to know as much as I can. But there is no circumstance with a patient like this where having a behavioral health clinician colleague and a community health worker is not going to greatly expand my capacity because I don't know that stuff. I can know about it, like, oh, yeah, cognitive behavioral therapy is a great idea here. I don't do cognitive behavioral therapy. When I'm sitting with someone who does it, they're going to inform me in ways that are productive. And I'm going to be able to inform them in ways that are productive. Add a community health worker in there, well, they can make the conversation targeted and pragmatic because they actually work with the resources. When you pull these people together, when you are talking to colleagues that have different jobs than you, you're expanding your capacity greatly. We're not all islands, we work in teams. And if you don't work in teams, this isn't a lumberjack webinar. We're all in deeply collaborative fields. Know your colleagues and get them into these interdisciplinary conversations, even if it's not if they are in some way directed in clinical care. I can't tell you how many times I had patients that had social workers and community health workers that I've been able to call them and solve a problem. A discharge, for example. I've had patients I've been trying to discharge for months. I can get rid of them. And all I needed to do was talk to a community health worker to know who to call, who you get on the phone with, so you can find a relative. We will solve more problems if we work together, and medicine is interdisciplinary. I think physicians have kind of an old-fashioned view of the medical system. Sometimes we think that we're very important in it, and in some cases, we think that we own it. Um, Maybe 100 years ago, not now. This is all a group effort. We're all moving things together, and we all get different letters. And the more we can talk about things, the more we can coordinate things better. So talk to your colleagues. And I'm saying that one to sell it, but it's not always easy, right? Uh, what I can say is uh, those conversations build, and the more if you are able to have a conversation with your colleagues, you know enough about behavioral health to be able to ask about a key diagnosis. Do you think this is a risk here? Or what would you do in this circumstance? Knowing how to discuss things with your colleagues, that's the infrastructure for connection. Otherwise, we end up siloed. So let's connect. Shared language and having regular conversations, it builds on each other. Trust me. Also makes work better. So talk to each other. Next slide. Let's see what they said. The physician. Um, First, this is a largely clinical perspective here, and by clinical I mean internal medicine and diagnoses based perspective here. This is the one who's putting people in the boxes and choosing what boxes. Physician notes the substance abuse appears coping driven and situational. The bullying and the social isolation are identified as the key drivers. The recommendations were to screen for co-occurring anxiety and depressive symptoms. Yes, this patient is likely experiencing these, but needs to be formally diagnosed. No indication of pharmacotherapy or specialty addiction treatment. I agree. These are minor to moderate abuse issues. Coordinate with social work and CHW for prevention-focused intervention. That's a no-brainer there. And follow close for reassessment with escalation if needed, if substance abuse or risk of suicide ideation. Substance abuse gets worse, or there's other risks, suicide ideation, and so forth. Watch, create stability, monitor. That's the physician perspective. Who's next? The social worker. Social worker recommends individual therapy to explore the coping strategies. 100%. Support mechanisms, self-esteem, and emotional regulation. The social worker wants to build that emotional, intellectual, regulatory capacity in the patient. That's what they want to do. The social worker brings in the Lego bricks and has the instruction and helps the patient assemble them. And that Lego castle is the patient being as well functioning as possible and having coping strategies. That's a new analogy. I hope you liked it. Family therapy to support communication between John and his parents. I know Mary likes that idea because she was talking about family connection. So family therapy, ka-ching. Evaluation of the school climate. If bullying has been formally addressed, it may be appropriate for the social worker to reach out to the school social worker to discuss this. That could be a game changer. Different schools, different strokes for different folks, different states have different systems, but in most cases, that would be recommended if it's becoming this severe. Next slide. Who's next? The community health worker. This one's my favorite. I've never met a community health worker I didn't personally like. Perform home visits to assess the day-to-day environment. Assess and identify gaps in inclusive recreation. Link him to activities. Connect John to inclusive or adaptive community activities. Get him out there. He can't be isolated if he's not isolated. And supporting the family with practical strategies. It's hard to have a child with physical disability. It's extra work. Having a child is a lot of work. What if you had to put an extra 20% on top of that? More time on top of that. It's a lot of work. Supporting the family is a good way to support John. Uh, and communicate the contextual insights back to the teams through well-written notes. Community health workers, make sure your notes are good because we read that stuff and it is key context. When there is a internal medicine or primary care mystery out there, this is the one that solves the mystery is the community health worker note because it has some social context that we never would have thought about. So make sure those notes are good because they're read and they're important. And also a key place where community health work is going as a profession. If you can document well, you're more valuable to your employer. You have a safer job. Be a great documenter, and you will be a better community health worker. Next slide, please. The shared income outcome here. This is a serious situation, but medical risk is in the low to moderate category. This is where we intervene to stop the patient from developing a severe substance abuse issue. Emotional distress and environmental isolation are the primary intervention targets throughout the team. You can shoot different guns, but make sure you have the same target, is what I always say for this. You got to be focused on the same things. Clinical care counseling and community support are primary targets for intervention, and we have clear plans for follow-up. We have clear plans for role coordination and escalation if risk increases. That's how we get John from someone who is at risk of developing severe substance abuse to just another guy out there living a healthy life. The road forks. Next slide. And I think that's it. Thank you so much for joining us, for serving who you serve. Next session, we're going to switch gears. We're going to keep our youth and disability here, and we're going to focus on veterans care disabled vets, and behavioral health. It's a hard demographic to treat, but we're going to crack in and try to understand them from their own perspectives, so we can get them in the exam room and keep them healthy.
Yep. Great. Thank you so much. Everyone, thank you for joining us today. And please, just a reminder to please complete your post-evaluation and let us know how we did. So we'll see you next week on Wednesday at the same time. Have a great day, everyone.